Hello, this is Dr. George Rogu, and I'm coming here to you today from the Independent Pediatric Collaborative of Long Island. I am the president of the IPCLI, and I am also the CEO of RBK Pediatrics and Urgent Care Services, also in Long Island. Today I'm going to talk to you about clinically integrated networks and how they can enable you to run your practice more smoothly and independently. Now, running a pediatric practice, as you all know, is getting harder and harder every single day. When I first started practice in 1996, very simple. I went in, I wrote on a piece of paper, we sent out a paper HICVA form, life was good. Now there's computers, population health, there's a whole bunch of stuff going on. It's very complicated. We also have to worry about health plan consolidation, provider aggregations. We have to worry about decreasing reimbursement on fee-for-service and capitation models. The fee-for-service model is changing to the also known as value-based care model or pay-for-performance model. The QIP quality incentive programs are also morphing into value-based, controlled by entities. There's a big demand for advanced infrastructure and technology. There's data integration. There's analytics. We have a whole lot of increased regulations from patient-centered medical home, meaningful use, HEDIS, other state regulatory bodies, MIPS. Then there's the cost of doing business, everyday business. It's rising. Supply chain deficits. Because you're not a large organization, a solo practitioner, there's limited purchasing power. And most important, because you're a solo practitioner or a small group, there's very little leverage with the insurance carriers. You take what they give you, and you're supposed to say thank you. Now, no wonder doctors are giving up. Why would anybody want to stay in independent practice with all this red tape and bureaucracy? Well, I went into private practice because that's what I wanted to do. I wanted to have my own office. I never wanted to work for a hospital system or an academic center. And you know what? I have to say I have the best job in the world. Independent practice is the best. We lived through the technology times. We always had a job. We lived through the real estate bubbles. We're living through COVID. We're living through everything. Yet independent practice still is alive. And we're the happiest people in the world. Now, unfortunately, this new world of medicine has become more of a business. Unfortunately, a lot of the physicians are not so business savvy. We all know that there's increased work, there's increased expenses, and then there's decreased revenue. And with that, you have decreased money that comes into the doctor's pocket at the end of the day. In the old days, like I said, you saw the patient, you threw up a shingle, you made a paper claim, HICVA form claim, a check came back at the end of the month, life was good. All we had to do was see patients and send bills. And I heard way back in the late 60s, early 70s, before my time, people actually used to come in and pay with cash, and they didn't even have to send bills. They just saw the patient, time of service bill, and that was the end of the story. Now, as we all know, today things have gotten really complicated. Everybody wants you to believe there's no money in private practice medicine. Yet it's very interesting that everybody wants to get involved in medicine. How is that? Well, they know that the pie is there. They just want to eat more of the doctor pie. Big academic centers are passing this attitude out to its residents that nobody wants to go into private practice. They should all go into specialty care. They should go into academia, work for a hospital, a hospitalist system. So, the doctors, the young doctors, are saying there's no sleep, no money, no life for a medical student. That's not so true. It's so far away from the truth. But you do have to work really hard and really diligently, because the doctorate degree, the MD or the DO, does not guarantee you success. It just gives you a little bit of a head start. Now, these people that want to get involved in medicine are venture capitalist systems. They want to make a quick buck, turn around the profits, and sell it to another venture capitalist system. big hospital system want to gather up all practices. It seems to happen every 10 years when they want to consolidate practices so they can have their stream of patients and referrals and laboratory testing. Large networks want to take over practices. And unfortunately, some of these large networks are becoming owned by insurance carriers. So many levels are wrong. In hospital systems, as you know, medicine today is run by Nondoctor MBA suits. And the reason that this has happened is because a lot of doctors feel we didn't learn about medicine in medical school. We wanted to learn about medicine to make people better. Or they say that we're too busy to manage the day-to-day activities of the office, and that's why we can't do it. Some physicians feel that business of medicine is beneath them. Some physicians feel that they should just see the patients and they should be paid appropriately without doing anything else. Unfortunately, some physicians have drank the Kool-Aid which was served by the big hospital systems and said to them, "Doctor, go in a room, do what you do best, and let us take care of the rest." That's no good because the people are not happy with that. A lot of physicians just leave the business up to people they call managers that are really not equipped education-wise to manage an office. It's usually a family member or somebody who's been there for a long time. And then there's always the fears of Stark laws that doctors have to deal with. Unfortunately, what is a physician supposed to do? A lot of the alternatives out there are pretty dismal. You could sell your practice. You could retire early. You can join a hospital system. You can join a large medical group. You can join a large network, or you can become an employed worker bee. But all of these things have one thing in common. The story ends up with physician burnout all the time. This occurs simply because physicians feel overworked and underappreciated. They lose their physician autonomy. Their future is determined by the RVUs. There's physician burnout for people that work for big systems. And basically, a physician always has to ask for permission, usually from a non-qualified person that has nothing to do with medicine from the administration point of view. And it makes them upset. Now, all these things happen simply because physicians, when they were trained to lead. They have to be the captain of the ship all the time. But in a hospital or a system organization, these same physicians are now mandated to follow orders. Private physicians just cannot handle that. Now, our independent pediatric collaborative, well, we're not a large system. We're not a group. We're not a large group. We're not a network. We're not a hospital system. We're just a bunch of good old private practice physicians. And what we believe is we believe in independent practice. We believe in physician autonomy. They should do whatever they have to do at their local level. We believe in more physician leadership. We believe that leadership should be led by physicians and not by MBAs. We believe that a practice should keep and operate under its own individual tax ID number. They should also keep their EHR. And we believe we should work with and collaborate with like-minded private physicians because you know what? Collectively, we have a whole lot of experience. Nothing that the school or an MBA can teach you. So what are we to do about this? Well, we first need to recognize there is a need for change at your office level and for transformation. And the way to do this is to create a beneficial medical neighborhood that circles around pediatrics and pediatric subspecialties. We want to break away from the internal medicine world. And within this, we can incorporate behavioral health, nutrition, telehealth, urgent care service, and we can help develop profitable ancillary services within. In order to do this, we partner with experienced and like-minded private physicians. And when we do this, we can engage them, getting them to the table to share ideas legally, to share their EHR technology, and we can help augment areas for expansions within the organization. In order to do this, we basically collect data. We make dashboards with drill-down functionality and actionable insights. Now, when you organize a group together, you will have increased leverage to negotiate favorable payer value-based contracts, wraparound contracts, not the fee-for-service. And with the like-minded group, the group can organize and it can manage its growth and strengthen contract and purchasing positions. Now, this sounds exactly like the clinically integrated network, or CIN, that we created, IPCLI. In our group, practices keep their own individual tax ID at their local level, and they continue to operate under it. Day-to-day operations maintained at the local level. We don't change anything. We do, however, brainstorm and speak to each other about how we do different things. And if one physician has a great idea, why not share it with the group? All fee-for-service contracts and IPA contracts, or whatever the local practices have, remains as so. We don't change any of that. We do have, within an alliance with an IPA locally, we were able to extend into their messenger model contracts with some commercial payers. Like I said, everyone keeps their own EHR and keeps their staff and their work plans and workflows at their local level. We do aggregate data and create some centralized clinical dashboards, quality dashboards. And in a way we can do this with different EHRs is we pull universal files. And the universal files that are used for putting out claims and receiving claims are the 827 and 835 files. Every EHR has those. So we put that, and that's what scrubs, they get scrubbed, and you can see the quality measures on the dashboards. And with all the practices and physicians that we have, by accident, we have economies of scale on purchasing. And again, with doctors that are organized and do the right thing, you do have some industry leverage with the network of physicians. Now, joining our CIN, IPCLI, you get the best of all worlds. You keep your tax ID, you keep your technology, you work with like-minded physicians within the community that are no longer competitors, they're your friends. You improve medical quality, expand the network and the neighborhood. You have access to contracts and economies of scale, shared savings will come into play. And this is done all within the legal confines of our supergroup without walls. Now, supergroups without walls, the only way that this can happen is if you stay independent and you collaborate with other physicians. We need to understand in the private practice world that we're no longer competitors. The practice down the road is not the competitor. The competitor is the large system, the network, and the large multi-specialty groups. Those are the competitors. Those are the ones that will put you out of business. But if you create a clinically integrated network with people like you'll with the help of clinical dashboards, you'll provide quality care, and with quality care will come money. I learned from my father, who is not a physician, when I went to medical school. He always said to me that if you do good medicine, then the money will follow. But if you follow the money, you will never do good medicine. Think about that. So a question that I am asked all the time is, all right, so if I join the CIN, what's in it for the doctor's office? Well, first and foremost, things that you can touch and you can't touch, intangible and intangibles. Some of the things that you have is you get to work legally with other like-minded practitioners and people in private practice within the community that you may have heard of or may know about but never met personally. And together you can work on day-to-day activities, you could share resources, You work on quality measures and PCMH things. We share the technology. So we pull data from all of our EHRs, whatever it may be, and we create clinical dashboards. And this way we can benchmark the CIN, how it does as a group, how it does individual practices against each other, against the group, and then within the group, the practice and the individual doctors. And with this, basically, there's revenue optimization, because if you do good quality, you will get wraparound quality value-based contracts and quality incentives. Another thing that we can get from joining our CIN is group purchasing, or economies of scale. By putting all our physicians together, we have really, really good rates on health insurance for the offices, professional malpractice insurance discounts, which are pretty significant when compared to the solo practice level. We have some contracts that help us with medical and office equipment and supplies, discounts on the IT and the data analytics, and we're able to obtain meaningful use PCMH and quality incentives and value-based contracts, because we're pooling all our patients together as one big group. Whereas if you were by yourself, you only had a handful of patients. But if you have a couple of practices with a handful and a couple of bigger practices, all of a sudden you have a very, very large patient pool. And it's all about the roster, how many patients are within the contract. Joining our CIN, we've already proven and we've secured some extra income and monies with some value-based contracts in the past. We made significant shared savings and quality incentives in 2020 with Fidelis Care, and in 2021, the results are being tabulated right now. We have some new contracts with some value-based managed care contracts in 2022 for United Healthcare Community Plan, and this is via an alliance with a local IPA that's for pediatrics only. We have secured a contract with Affinity Molina Healthcare. From the commercial contracts point of view, we do have an alliance. We have that alliance with that IPA, and through our connection with them, we will be able to share some commercial contracts from Blue Cross Blue Shield, Aetna, United Healthcare, Oxford, and Cigna. And of course, software partnerships to help manage your quality and give better margins. As you know, the economies of scale are pretty critical to making good money. Medical supplies, when one practice buys one box, it's a larger price. When a group buys 10 boxes, that price gets discounted. It's simple as that. Same thing goes for vaccines. If you buy as a big group, you will get significant discounts on the vaccines. Medical malpractice, significant discounts, the ability to enroll in health insurance, discounts on consulting services, and IT infrastructure. Now, how do we accomplish all this? That's a good question. The way we did this was by placing the medical corporation ownership and governance into the hands of private practice physicians. Not hospitals, not networks, but community physicians. We created a legal entity where we met all the federal and state regulatory requirements to stay out of trouble. And technology has enabled physicians to be able to better focus on quality care and help with improving the outcomes. It's no longer a big task asking physicians to upload data and to do the right thing and to find patients that have quality metrics that need to be managed. And our biggest thought is, if we proactively position the Long Island Pediatric Supergroup without walls in the market, we will be there when future opportunities occur, because we are a big network now and we're an entity, we're a force. And once again, allowing resources and sharing practice functionality, HIT, and so forth. Now, shared priorities in office culture. The mission of the practice is to get the physicians to work together. We need to work together, yet we need to keep our autonomy at the office level. We want to increase our income by providing quality medicine. We want to try to control the day-to-day of operations and pick best practices and share them amongst all the offices. And very important, and I repeat, keep the individual practice's tax ID number. We want to stay independent and not worry about being taken over. And most of all, we want to keep our EHR technology and infrastructure. What I've seen over the years when a practice was taken over by a large entity, they automatically, almost immediately forced the practices to change to their EHR because that's how they're able to do the population health and the billing and the progress notes. I mean, to change your EHR for no good reason, I mean, that's not good enough for me. If your technology works, keep it. If your technology is not working, then obviously that's when you should change it. But for us, it doesn't matter. We pulled 827 and 837 files. Practice transformation. Well, you know, that's the new buzzword for success in medicine. Without practice transformation, you're just a dinosaur from the 80s. And within this practice transformation, there's a lot of things that we have found in the patient-centered medical whole model, which, if you know, patient-centered medical whole model was based upon pediatric care. People that are in pediatrics, they've already been doing this forever. The problem was always the internal medicine groups. And within this, you have care coordination, patient education on health, patient and caregiver experience has to improve, quality reporting and improvements, data analytics with actionable insights. You need to empower physicians to do things. You need to manage the population health, telemedicine, access to care. This is all practice transformation. You know, those practices that work from 10 to 4, Monday through Thursday, skipping on Wednesday, never open on the weekends. Well, those models are a thing of the past. And that's why you have all these urgent cares and minute clinics and all these other organizations that saw the hole in internal medicine and said, all right, there's a lot of business over there. Let's service that population. Now, in private practice, it's gotten to the point where we're in this together. We need to work together to survive into the next 20 years. If you think for 1 minute that practice transformation could result in lower revenues and higher expenses and lower earnings and more time, you're correct. If you think from an operational and administrative point of view that there's a lot of change in healthcare with significant downside risk and huge investments in time and money, you're correct again. And if you think that the hospital system vultures and the network vultures are waiting for you to just give up after this COVID-19 crisis, you're darn right, you're correct. They just can't wait for a practice to give up. But private practice has always been, you know, the sweetheart of medicine. Everybody used to want to go into it, and all the patients wanted to go to them when, you know, the services were the same. But, you know, big systems, they do have technology and they have better, you know, access, and they better, you know, front end staff and phones. But, you know, in private practice, we're more nimble. We can do things. We can change things. We don't have to have 15 meetings to change a policy. We just, you know, talk. We have a thing that doesn't work. We want to change it to something that works. We make it so. So if you feel there's no money in private practice, well, that's what they want you to believe. You're dead wrong. They want you to feel that there's no money in private practice. There is. Otherwise, they wouldn't be coming after you. Now, if you want to connect with me, here's my email address, drrogu@rbkpediatrics.com. It's my direct cell phone number, the independentpediatrics.com website if you want to get some information about the board of directors and who's involved. And I would like to share with you now our little marketing video that it's 2 or 3 minutes that basically explains everything in a nutshell. It's really, really nice. So if you can look at this and listen, and you'll see how it'll bring it all home. I'll be right back.
Pediatric Collaborative of Long Island, or IPCLI, is an organization developed by private pediatricians for private pediatricians who are working together to stay independent. Our goal is to provide better pediatric quality medical care while preserving our individual practice identities and autonomy. Private doctors' offices are coming together around quality assurance, decreasing costs, and unnecessary utilization, and we believe that payers would be excited to work together with us. Insurance carriers are also facing their own pressures to control healthcare costs. If we help them to reduce the overall cost of care, payers will be more inclined to share the savings with organizations that can demonstrate quality, and that's a win-win for everyone. In today's busy world of pediatrics, it feels like there is never enough time for the doctors to spend with their patients. This is aggravated by electronic health records, medical guidelines, and coordinating care for kids that have more complex needs. The office staff is too busy trying to manage the day-to-day activities of scheduling patients, making referrals, and tracking down insurance information when payers deny claims. With all of these outside distractions and regulations, how is a private pediatric group supposed to compete and still take care of the children? A pediatric-specific clinically integrated network is positioned to help change all of that. We bring doctors back to caring for kids while still efficiently managing their private practices. As a pediatric CIN, community pediatricians can collaborate and focus on common childhood issues such as asthma, childhood obesity, immunization rates, and behavioral issues where the greatest impact could be made. But with all those patients being managed in primary care, this sounds like a whole lot of work. Collaborating with each other, we can engage the expertise of many years of experience and help each other in problem solving. Collectively, we develop systems implemented across the medical neighborhood. What is one practice's problem today could have already been resolved by another practice. We can share this knowledge, experience, and stop reinventing the wheel. Population health has also become the new normal. With our pediatric-only clinical dashboard, we have extracted data that resides in different EHRs. We have created a centralized data hub that collects data from different EHRs and processes them into an understandable clinical dashboard. We have successfully merged data from PCC, eClinicalWorks, and Office Practicum. Adding other companies will be just as easy. With IPCLI, private offices will have a virtual community of pediatric physicians who have come together to improve quality, increase efficiency, reduce costs, and who can prove it. Now that there is an organization that has come together around these issues and will allow you to retain your own autonomy and EHR, why would anyone think that they need to join a large impersonal healthcare system or network? Private pediatric practices that are self-managed are better able to collaborate with their patients and insurance carriers. This allows the opportunity for greater innovation and satisfaction for all. With IPCLI, or as we like to be called, Independent Pediatric Collaborative of Long Island, everyone wins, especially the children, and that's the most important reason. Visit us at independentpediatrics.com.
Well, that little video just shows you, it just touches on what can be done. And the future of independent practice basically is dependent upon the individual physician. I mean, I'd like to go to work, and if I do good things and I'm successful, I have myself to blame. I did it. But if I don't do well and the practice doesn't do well, again, I have myself to blame. But if I work for a hospital and I work really hard and I'm not successful, I don't want to get involved with other people telling me what to do. So please, 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 please stay independent and let's work together and do good things. Thank you, and feel free to call me on my cell phone, shoot me an email. I am always available. Thank you.